Hi everyone, this is Emily Bach. I'm a Women's Health NP student at Regis College, and I will be presenting my pocket guide. Starting with the HPV vaccine, or Gardasil 9, this is a vaccine that prevents against the HPV virus, which protects against genital warts and other types of warts and cancers. This shows the different types of strains it protects from, the 2-dose versus the 3-dose indications and the age, as well as the dosing schedule. And as well as the contraindications and adverse events. This slide consists of a very helpful handout from the CDC regarding the HPV vaccine, including the indications, the strains that it prevents, the recommendations as far as age and dosing schedule, and it also tells how to administer the vaccine. This next slide regards cervical cancer screening. So cervical cancer screening should be done from ages 21 to 65. Ages 21 through 29 should have PAPs every 3 years, while women 30 to 65 should have PAPs every 3 years, or HPV testing alone every 5 years, or co-testing with HPV testing and Pap smears every 5 years. Women who are older than 65, as long as they have a negative history, and have had normal results within the past 10 years, they no longer need to do Pap smear testing for cervical cancer screening. Women who have had a hysterectomy, as long as they didn't have a hysterectomy for like any type of issues with their cervix, and they have had their cervix removed, as well as having a negative history, as far as like no like CIN 2 or 3, then they can stop having cervical cancer screenings. The exception is that women who have been exposed to DES or have HIV or are otherwise immunocompromised need PAPs yearly. These next few slides consist of Pap smear results. I made a chart with the different results that can occur with Pap smears and the next steps. So this includes like the negative for intraepithelial lesion, ascus, LSIL, and what the next steps are for after you have this result. This slide is just a continuation, same thing, a chart I made with the Pap smear results and the next steps. Here is a super helpful Pap smear tool that my preceptor showed me at clinical. So the American Society of Colposcopy and Cervical Pathology created an app that has the current guidelines and recommendations. So you type in the patient's age, and their screening recommendation or their results that came up. So if they were HPV negative and had LSIL, it will then populate what the next step is. Part of my pocket guide includes breast cancer screening, so women ages 20 through 39 should have a clinical breast exam every 1 to 3 years. Women aged 40 to 49 should have a clinical breast exam annually, but should also start having mammograms annually. Depending which guideline you look at, it says starting at 40, others say starting at 45. And then from ages 50 through 74, clinical breast exams annually and mammograms biannually, or they can continue annually. This slide is a chart I made of mammogram results, so it's categories 0 through 6, and it shows the different results and the next recommended follow-up. So for example, category 1, negative, recommend routine 1-year follow-up. So no changes in regular routine mammograms, as opposed to category 5, which is highly probable for malignancy, over a 95% chance of malignancy, so a biopsy is recommended immediately. This slide is a chart from Up to Date, so it's the breast cancer screening recommendations by different organizations, so like the American Cancer Society for one. So they all kind of have different recommendations. Some say starting mammograms at age 40, others say starting at 45, and then at age 55 it says that women should start having mammograms every 2 years as opposed to every 1, while some still recommend annual mammograms. So it just shows the different breakdowns of what different organizations recommend for breast cancer screenings. This slide covers anemia. So anemia is a decreased red blood cell volume measured by hemoglobin or hematocrit. Anemia is a hemoglobin under 12 or hematocrit under 37. This slide also includes the different causes of anemia. And the cause of anemia is determined by looking at the MCV and the retic count. I also included the normal MCV and normal retic count values. To the right of the slide, you'll see it's anemia evaluation tool. It's from UpToDate, and it shows kind of how you figure out, like it's an algorithm to figure out what type of anemia your patient has. This slide is an anemia chart that I made, so it includes the type of anemia with a brief description, and then on the other part of the chart, it shows which labs correlate with that type of anemia, the symptoms, and as well as the recommended treatment. This slide includes information on hypothyroid, so it's a definition, the types or the causes of hypothyroid, the risk factors, symptoms, signs, treatments, and labs that correlate with hypothyroidism, as well as when labs should be rechecked. To the right of the slide has a visual that I found from Pinterest that shows the signs and symptoms of hypothyroidism. This slide is very similar to the hypothyroid, except it's hyperthyroid instead of hypo. So it includes the definition, the type, so Graves' disease is the main cause of hyperthyroid, the symptoms, signs that you would see on the physical exam, recommended treatments, as well as which treatment should be used in pregnancy, and then radioactive iodine is another treatment option when medications fail. And it's important to remember as OB/GYN or women's health NPs that pregnancy should be avoided for 6 months after completing radioactive iodine treatment for hyperthyroidism. And then to the right of the slide includes another visual from Pinterest, this time demonstrating the hyperthyroid symptoms and signs. These next few slides of my pocket guide include contraception. So this first slide is the natural family planning slide. So that consists of fertility awareness, cervical mucus, temperature, cervical position, calendar method, lactation amenorrhea, and the withdrawal method. So on each of the different methods, I wrote the failure rate and the risks and benefits and how to follow each method. The next contraception slide includes the barrier method, so male and female condoms, diaphragms, cervical caps, and spermicides. So again, I included the failure rates as well as the contraindications and the risk and benefits and important details. For example, a cervical cap has to be inserted 30 minutes or right before sex and left in place for 6 hours, up to 48 hours. And then same thing with like spermicides. If you're using a tablet, it takes 15 minutes to become effective. This contraception slide consists of progesterone only, so progesterone only pills, Depo-Provera injection, Nexplanon, and IUDs. So I include the method of action, how the birth control works, the benefits, the disadvantages, who this birth control method is ideal for and who shouldn't use it, as well as like details including like Depo, the dose is 150 milligrams and it's every 12 weeks. Again, I included the failure rates for the progesterone or for the Nexplanon, that it's good for 3 years. This next slide on contraception includes IUDs. So the different types of IUDs, including the progesterone and the copper. So this slide includes benefits, disadvantages, good candidates and bad candidates, as well as the failure rates and how the method of action behind the IUD. So this slide is combined hormonal contraception, so it includes both estrogen and progesterone in either a pill, patch, or ring. So I included the failure rates, the good candidates, poor candidates, the risks and benefits, contraindications, and what signs to watch for with the oral contraception pills, as well as instructions. So, like, for example, the transdermal patch is apply 1 patch per week for 3 weeks and then have a week off without any patch, as well as just important information. For example, the NuvaRing tends to have less breakthrough bleeding compared to oral contraception, and the patch tends to have more breakthrough bleeding, so just important details that patients might find helpful. For example, like the transdermal patch, if the patient weighs over 198 pounds, this would be a less effective method for them, so they might want to try a different type of method. This slide includes emergency contraception as well as sterilization. So emergency contraception includes either the pills, Plan B and Ella, or copper IUD. I included the advantages, when it's contraindicated, the failure rates and side effects, as well as how, if it's an oral over the counter or a prescription, and when the pill should be taken. For sterilizations, I included tubal ligation for women and a vasectomy for men. I included the type of the procedure, the failure rate, and the associated risks, and how long it takes to become effective. This slide again includes contraception. My preceptor actually showed me this very cool website and app. It's called bedsider.org, so it allows a patient to compare different types of birth control. So on the left side, it shows that like it compares all the different types of birth control. So it includes like the failure rates and potential benefits, and like really just gives a good breakdown on all the different types of birth control. And then on the right side, you can compare 3 types of different birth control, and it goes in much more details regarding like risk, benefits, considerations, and just like general information on the different types of birth control. So it's a very good tool to use with patients. This slide again includes contraception, so it's the CDC summary of U.S. medical eligibility criteria for contraception use. So it includes like the different categories. So a patient with like certain conditions, like if they're 35 and a smoker, they shouldn't have estrogen. Same thing if they have like a clotting disorder, what types of blood birth control products they can use. So it's a very helpful chart for providers. So this slide is about gestational diabetes. So it includes the definition of gestational diabetes, the pregnancy associated risks, and when screening should be done. So diabetes testing should be done early in the pregnancy for women with a BMI greater than 25, have had a prior pregnancy where they had gestational diabetes, a history of impaired glucose tolerance, or an elevated A1C greater than 57 but hasn't been under 6.5, so not technically diagnosable as diabetes but is a pre-diabetic. This could be someone with like PCOS. Advanced maternal age, so 35 and older, a family history of diabetes, a high risk ethnicity, so like African American, Latino, Native American, Asian American, or Pacific Islander, as well as a history of cardiovascular disease, hypertension, hyperlipidemia, PCOS, or physical inactivity. If a woman fails a glucose tolerance test early on in her pregnancy, like at the initial visit, she should be diagnosed with diabetes rather than gestational diabetes, because gestational diabetes develops in the 2nd or 3rd trimester. If a woman who is high risk for gestational diabetes and is screened at the initial visit passes, she should repeat a 3-hour glucose tolerance test between 24 and 28 weeks. And then routine gestational diabetes testing, it takes place with either a 1-step or a 2-step at 24 to 28 weeks. This slide for gestational diabetes shows the breakdown of the 2 different approaches. So there's the 1-step and the 2-step. So the 1-step is recommended by the American Diabetes Association, while the 2-step is more common in the United States. I believe it's used like 90% of the time. So that includes a 50-gram glucose tolerance test. That's only 1 hour, non-fasting. If they fail that, then they have to do a 100-gram, 3-hour glucose tolerance test, where if they have 2 abnormal values, then they are diagnosed with gestational diabetes. So this shows the different criteria for abnormal values. So the 1-step, the 75-gram, 2-hour, the fasting, the 1 hour, and the 2-hour, and that's only, they need 1 abnormal value to be considered gestational diabetic, as opposed to the 3-hour glucose tolerance test. They need so either the fasting 1 hour, 2 hour, or 3 hour 2 of those values have to be abnormal to be diagnosed with gestational diabetes. So this other slide includes gestational diabetes, so the diagnosis I kind of went over on the last slide, and then the treatment options. So the goal is to maintain the blood sugar in a normal range, as well as the intervention. So it's usually diet and exercise, as well as checking their blood sugar 4 times a day, so a fasting, and then 1 to 2 hours after eating a meal. If they fail to control their blood sugar, they should be treated with insulin or metformin if there's like issues with either they refuse to give themselves injections, they're not capable of doing it, or there's a concern with cost, then metformin could be indicated, but it's definitely not the #1 recommended treatment. Uncontrolled gestational diabetes or gestational diabetes being treated with insulin metformin, a woman should start antenatal testing at 32 weeks and should be induced at 39 weeks. To the right, there's a table that includes the blood sugar goals that we want gestational diabetics to be at. This slide regards cystitis or a bladder infection, includes the definition, the most common bacteria that cause infections, subjective data, as well as objective data. To the right, I have an image that differentiates between cystitis and pyelonephritis, including the signs and symptoms. On this slide, I made a chart differentiating the different symptoms between cystitis, vaginitis, urethritis, and pyelonephritis because they have a lot of symptoms that overlap, so it can be difficult to determine. This chart helps me determine if I have a patient presenting with dysuria, what route I should go as far as diagnostic testing and for treatment. This slide includes a urinalysis result. So a urinalysis for suggesting a UTI is most commonly seen with a positive leukocytes, and positive nitrates are the 2 most specific tests for diagnosing a UTI. Here I have the different breakdown on all the different aspects of a urinalysis and what abnormalities mean. This chart includes cystitis treatment, so the different antibiotics with the correct dose and length of time. This slide includes the different types of prolapses, so what the prolapse means, and then I included a visual of the different types of prolapses, which is helpful to show patients because they're able to actually visualize what's going on. This is the different stages of prolapse, so POPQs are done to determine the stage of a prolapse. So this includes the different criteria for staging the prolapse, but it also gives a good visual so patients as well as providers get a better idea of what's happening. This slide includes the different prolapse treatments, so vaginal estrogen, pessaries, pelvic muscle exercises or pelvic floor PT, as well as surgery. This slide includes information on STIs. So the CDC actually has an app that helps, it's an app for providers, so it contains all information like current guidelines and recommended treatments for STIs. It includes like symptoms, as well as like information on expedited partner therapy and the different treatment options, including like if a patient has an allergy to penicillin, what they should be treated with instead. This is a slide on STI treatment. So this is a summary of the CDC treatment guidelines for STIs. So it shows all the different STIs and all the different possible treatments. It says it's like for a wall, so it's like supposed to be hung up in like the office, but I figured it was a good idea to put in the PowerPoint. This slide covers abnormal uterine bleeding, so it defines the different types of abnormal uterine bleeding. So what is an abnormal period? So this includes intermenstrual bleeding, bleeding or spotting after sex, menorrhagia, oligomenorrhea, polymenorrhea, menorrhagia, amenorrhea, and postmenopausal bleeding. This slide again is on abnormal uterine bleeding. It includes palm coins, so the different types of causes of abnormal bleeding. So there's PALM, which stands for polyp, adenomyosis, glioma or fibroid, and malignancy or hyperplasia. These are structural abnormalities which cause AUB, often asymptomatic. And then there's COIN, which is the non-structural causes of AUB. So COIN coagulopathy, so like bleeding disorders, ovarian dysfunction, endometrium, iatrogenic, so other like medical causes, for example, like medications or an IUD, and then not otherwise specified. Here are the different references I used throughout the PowerPoint in my Pocket Guide. Thank you so much for watching my presentation, and I hope you enjoyed it.